Okay, so we're going to talk a little bit about central vein access and give an overview of what we're thinking about during some of these procedures and how we approach central lines. And so when we talk about central lines, we're talking about this bit of anatomy here. So you have relatively simple central vein anatomy. You've got an IJ coming from the right and left neck, feeding into a brachiocephalic vein on each side that then goes into the SVC. And this vein coming back from the arm is underneath the clavicle, so it's obviously called the subclavian vein. So subclavian, subclavian, jugular, jugular, and that's more or less a high level overview or a 30,000 foot perspective of the main central veins. And so a central venous catheter is going to be a catheter with the tip that ends up somewhere in this area. And so one of the things, or the main thing we think about in central vein access, is this phenomenon that I'll describe here. So wherever a man-made object touches a vein, it has potential over a long period of time, meaning multiple months, to create a foreign body reaction. And that more or less means scar tissue forms and thickens the wall of the vein and can create narrowing in the vein. And so, for example, if we look at the anatomy here, and let's just go through our different sites of central vein access, and I'll explain, is let's say, for example, we go with a left IJ access. So this catheter, this tube that we're putting in, the vein goes in here, and it comes down and makes contact with the vein here, and hopefully the tip ends up in an area that's more free floating where there's cardiac motion. And so at the entry point, at the subclavian or brachiocephalic contact point, and in the SVC, there is an area of prolonged contact with the vein where scar tissue or narrowing can form. And so this can be a problem long-term from the left. And so, for example, we see a lot of left subclavian ports, which this left subclavian access, you can imagine, is the worst chest central vein access, because you have this long area of contact with the left brachiocephalic and subclavian veins. And then in many surgeons, they'll put the port catheter too short. So we end up with this phenomenon of the surgical port being left subclavian, having prolonged contact with the brachiocephalic and subclavian veins. And then the tip is chronically in contact with the SVC. And this results in a central vein occlusion. And so left subclavian access is probably the least preferred access and can result in occlusions in areas of narrowing. Similarly, prolonged contact with the vein can accelerate the process of development of a fibrin sheath, which is, again, a sleeve of tissue that sort of forms along the tip of catheters. It's less likely to occur when that catheter tip is in a mobile location, like in the right atrium. And so conversely, the right IJ, you can see, has really a straight shot down anatomically from the access point into the heart. And so, so really with right IJ access, you really only develop narrowing, again, just broadly speaking, you only develop narrowing at the entry point. And that is something that we see really from time to time, not all the time, in prolonged access. And so again, this occurs over multiple months. It's a lot bigger of a deal in a long-standing dialysis catheter because it may be in for years. It's a lot bigger deal in a port because they tend to be in longer. Probably less of a big deal in Hickman catheter because they tend to be about a 6 to 12 week antibiotic course that they're used for, and then they come out. Not in most circumstances, not enough time to create that prolonged kind of scar tissue endothelial response, as we call it. This also gives you an idea as to why PICC lines need a referral from nephrology. These veins are very important for dialysis fistulas in patients who are on dialysis or who may be on dialysis in the future. And if there's prolonged PICC line contact with the axillary, subclavian, and brachiocephalic veins coming from the left arm, then you could see how you could end up in pretty short order with a central venous stenosis. And so that's an overview of the anatomy and kind of how we think about that. It also puts in context why we work really hard to use IJ access and why we work really hard to use the right-hand side of the chest. And so a quick overview of the kinds of lines. We use PICC lines, Hickman catheters, and ports, and they're functionally very similar, like I mentioned. a couple things about ports. And so really lines are important in context of their use, but also their risk. And ports are an implantable device underneath the skin in patients who are not typically undergoing long-term antibiotic use, as is the case with Hickman's. And so the thing we worry about with ports the most is infection risk, and they have a higher rate of infection because of that. And so a couple of things that we do here, so we give Ancef, or we give an antibiotic, and that covers gram-positives, or it covers bacteria that could be on the skin. The way that we prep ports is also really important. And so we ask at least from nipple line to ear to be fully prepped in the site that we're placing the port. There should be at least 6 inches of prep on either side of the access site for the port. And it's best to completely remove the patient's gown from their chest from the port procedure. If it's just underneath the sticky portion, then there's a possibility for contamination, which is a big deal. Question comes up every year, every couple years, about antibiotic irrigation or irrigation in general of the pocket. It's never been shown in studies to be statistically significant, although in every large study there is a trend towards a decreased infection risk, and so it's something that in a large population probably prevents a few infections, but it's not something that has a real significant impact. And so that's why you see a little bit of a lukewarm opinion on it amongst us. I personally feel that it's the best option in terms of why not, right? If it prevents even less than 1% of infections, it's probably worth doing. And it's also probably worth noting that the government now tracks our implantable device infection rate. And so it's kind of a big deal. This is under a lot of scrutiny. So all of these sterile elements are very important for ports. And our group gets a report on these from time to time. Last thing is specifically for ports, in terms of port size, I think this is subjective. I think most operators are of the opinion that if the patient is large enough that you can't distinguish the clavicle, or you can't visibly see the clavicle, if that makes sense, then that's a pretty good indicator that the regular large size port is appropriate, because it has a lower rate of flipping and it's easier to feel and use given its larger size. And more or less everybody else can have what we call a mini port reservoir. So I hope that helps.